talks. So Florence Angioni is the next one. And she's now a senior PRM in Lariboisière Hospital, but she's going to present her work that she's done in Garches when she was a resident. So thank you, Florence.
Hello, everyone. Today I'm going to talk to you about microinvasive percutaneous needle tenotomy to treat neurological foot deformities. So first, acquired deforming hypotonia is defined as any joint deformity with decreased range of motion and increased resistance to passive movement, which can lead to a wide range of functional impairments, discomfort, or many other limitations in daily life activities. Treatments of acquired deforming hypotonia can prevent functional consequences. They are diverse and include botulinum toxin injection, chemical neurolysis or neurotomy, and classical open surgery. The surgery all bear risk of general anesthesia and complications such as bleeding or infection. Tenotomy is a technique that is used since the 18th century, and it was then used to treat clubfoot in Ponseti technique. Since recently, we use this technique in frail patients under local anesthesia or short-acting sedation. So the muscles are put under tension by passive mobilization, and we use the bevel of a needle as a blade to cut the tendon with repeated transversal movements. At the end, the tenotomy is complete when we have a suppression of the feeling of resistance and an increased range of motion. There was many studies about this technique. They showed that it was effective in fulfilling non-functional and functional objectives with few complications. These results were observed in 3 to 6 months after the procedure, which is a short period of time, and no specific assessment of this technique for treating foot deformity was done. So our objective was to evaluate the persistence of percutaneous needle tenotomy functional effectiveness in patients with acquired deforming hypotonia of the foot. It was a monocentric retrospective study of all the tenotomy who were made between January 2016 and December 2018. We used complete tenotomy for most of the muscle except for the triceps. It was lengthening techniques like Z-lengthening or gastrocnemius recession. There was no immobilization needed for complete tenotomy, but for the triceps, patients has to wear walking cast for 4 to 5 weeks in order to let the tendon heal and avoid hypercorrection. So before the surgery, all the patients were seen in a multidisciplinary consultation with an orthopedic surgeon and a PRM physician. We determined the objectives to be achieved, whether they were functional or non-functional, and we determined the muscles requiring treatment too. We decided to make an intermediate evaluation by phone call between consultations because all patients are not always living close to the hospital and they have difficulty to move. So we did the evaluation more than a year after the surgery with a subjective perception of goal achievement using GAS. So goal attainment scaling relies on personalized evaluation to quantify progress toward predefined goals. It goes from -2 to +2, and in this case, it was graded like this. Deterioration compared to the preoperative stage, no change, 0, the objective was reached, +1, it was exceeded, and +2, it was the best result we can imagine. Progress toward the objective without it being reached was scored -0.5 during the evaluation, and then it was rounded to -1 for statistical analysis. We also assessed the comprehensive care and occurrence of complications. So between January 2016 and December 2018, there were 228 percutaneous needle tenotomy procedures. 137 involved the feet, and in total, we assessed 100 procedures for 85 patients. Mean age at the time of the surgery was 51 years old, and most of the patients had acquired brain injury. The other have cerebral palsy, neurodegenerative damage, spinal cord injury, and peripheral neuropathy. The primary objective of tenotomy was facilitate work transfer for half of them, to ease the pain for a quarter of them, and for the others was to facilitate the wear of shoes or orthoses to heal the wound or to facilitate positioning. Telephone assessment took place 30 months after the surgery in average, and we can see that the objective was attained for 64% of the intervention, and patient global assessment was 8.65 over 10 in average. There was no serious complication, and the most frequent one was recurrences for 16% of the interventions. So we can say that it's a technique that provides functional and non-functional benefits that persisted over a long period. It is well tolerated, and there's only few recurrences. And if we consider all the surgery with progression, it represents 81% of the surgery, and we find the same number for classical surgery in the literature. But this was a retrospective study, and we can think that during the preoperative multidisciplinary consultation, we integrate the patient in a specialized care network, so the comprehensive care may have overestimated the tenotomy effectiveness. In conclusion, percutaneous needle tenotomy provides functional and non-functional benefits that persisted over a long period. It is well tolerated, and there's only few recurrences. It should be proposed systematically at the frail population, and in the long term, it may be an alternative to conventional surgery. Thank you.
Okay, we talked with François Genet, and since the last part is a bit different from the rest, we can start the discussion now. So if you have questions, you can go.
If there are limitations just because you did it retrospective, are you going to do it prospective now so you can monitor your outcomes?
It's the idea.
Il y a aussi des questions. Sorry, are there any questions for the previous presentation? Nicolas.
Thank you. Thank you to both. Wonderful presentations. In regards to your IMU sensors, one of the major concerns I have, and I've tested many of them, I have not tested yours or your algorithm, is that IMU sensors are excellent at being used for normal walking, but for pathological walking, they don't work as well. There's lots of work being done to try to address this, so I'd be interested in your opinion on that.
Of course, it's the real problem of it's the problem of IMU, but it's the challenge of our team because our system work very well with normal walk, but with a patient with pathology, it's more difficult. That's why we have a laboratory with mathematicians, very good. We are specialized in algorithm, and their goal is to obtain an algorithm we permit to study each walk, even the most worst. So the most difficult part is to detect each steps I think you know that. Even if in hemiparetic the steps are different, or in multiple sclerosis sometimes there is quite no steps. So to help the algorithm to train to detect steps, we use a get right to identify manually steps, and after to train the algorithm. But it's the challenge. That's why even if it's work for healthy subjects or osteoarthritis or hemiplegic with a good walk, we don't know if it will be pertinent for our patients. We have a very worst, very bad walk.
I just wanted for you to clarify that, because it made it sense like you already have it in place and you're collecting data and moving it into the algorithm. So it's important for the audience to understand that there are some challenges.
Yes, of course. Thank you. You're right.